Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is on pneumothoraces. A pneumothorax is an abnormal collection of air in the space between the lung and the chest wall. There are several types of pneumothorax which you should be aware of. These are broadly divided into traumatic, tension, and spontaneous. Spontaneous pneumothoraces are further divided into primary, which means that the person has no underlying lung disease, or secondary, in which they do have an underlying lung disease. Symptoms of a pneumothorax include a pleuritic chest pain, as well as breathlessness, and the degree of breathlessness correlates with the size of the pneumothorax. It's important to note that pneumothoraces can be asymptomatic, particularly when small. Otherwise, symptoms usually are characterised by being sudden onset in nature. When you examine someone with a pneumothorax, they will have reduced chest wall movement on the affected side. Their trachea will be deviated, and it's important to note as to which side the deviation takes place. So in a large pneumothorax, the deviation of the trachea will be towards the lesion, whereas in a tension pneumothorax, it will be away from the lesion. There is reduced tactile fremitus, as well as hyperresonant percussion over the affected area. There will be decreased or absent breath sounds, as well as reduced vocal resonance, and the person may be cyanosed. There are some risk factors to be aware of in terms of the risk of developing a pneumothorax, and these include smoking, recent interventions such as a pleural aspiration, central line insertion or other surgery, obstructive lung diseases such as COPD and asthma, trauma, and Marfan syndrome, which is a connective tissue disorder. When investigating someone with a pneumothorax, it's important to take a thorough history and examine the patient, as well as taking a full set of observations. An ABG will be important, as well as a chest X-ray and, in the longer term, a CT thorax. It's important to note, however, that in suspected cases of a tension pneumothorax, or if the patient is unstable, you should not be waiting for any imaging. Management of a pneumothorax depends on its size as well as the person's history. So if it's less than 2 centimetres with no underlying lung disease, it should be for supportive management only. And if it's greater than 2 centimetres or symptomatic, the person will need a needle aspiration. If aspiration fails, they can then go on to have a chest drain. So those are the broad principles of management. However, this particular schematic shows it in much more detail, and you can look into this in your own time, but it goes through who requires further intervention, or in which cases the pneumothorax simply requires monitoring. So if we now do a question, an 18-year-old male smoker presents to the emergency department with a 2-hour history of sudden onset breathlessness associated with pleuritic chest pain whilst running. His chest X-ray on arrival shows a 1.8 centimetre right-sided apical pneumothorax. He is referred to the medical registrar for management. Which of the following statements is correct? So our options are needle aspiration is not indicated, chest drain is the first line of management, given his pneumothorax is less than 2 centimetres, he can be managed conservatively. This is a case of a secondary pneumothorax, and he should be referred for smoking cessation therapy. So in this case, the correct answer is the last one, E. He should be referred for smoking cessation therapy, as this does increase his risk of having pneumothoraces, as well as, of course, other health problems. The reason, if we go through the others, why they are not correct, so needle aspiration is not indicated. This is incorrect because he is symptomatic. However, chest drain is not the first line of management, so this rules out option B. Option C says he can be managed conservatively, and this is not true again because he's symptomatic, so he will need aspiration. And D says this is a case of secondary pneumothorax, but again, this is not true. He does not have any known underlying lung conditions. And the fact he's a smoker does not count in terms of calling this a secondary pneumothorax, as he is under the age of 50, if you refer back to the previous slide with the schematic. Thank you for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in future. See you in our next episode.